All right, good morning, everyone. Welcome to the translational ground rounds, where we try as many times as we can over the year to bring in speakers kind of at that interface of, basic discovery and obviously clinical medicine. And so today we are absolutely honored to invite Dr. Gregory Payne from the University of Alabama at Birmingham. Just so everyone knows, this is a hybrid event. So when hopefully people can hear me online, we've got some moderators in the back keeping an eye on that. Alice is keeping an eye on it, and I'll be moderating questions online as well. So Dr. Payne is an associate professor of medicine at UAB and at the Hersing School of Medicine, and he's a physician scientist. So again, an excellent selection for our translational grand rounds today. He's the director of the UAB Comprehensive Cardiovascular Center, associate chief of cardiology at the Birmingham VA healthcare system, and associate program director for research in the UAB Cardiology Fellowship Program. He's also the director of the Cardiopulmonary Research Program at UAB. And again, this is really a tremendous example of leadership in this physician scientist role at that intersection of both clinical medicine and training, as well as in discovery research. His laboratory is very well recognized, particularly by the Department of Veterans Affairs and the NIH, of course, the mainstay of research funding in the US, which is harder and harder to get. So bravo to Dr. Payne to maintain that. And his research that he's going to be presenting today really focuses on the inflammatory mechanisms of cardiovascular disease, matrix remodeling, endothelial dysfunction, and he'll give us a bit of a flavor of his work that's characterizing the landscape of unstable coronary atherosclerosis, which of course clinically is vitally important. He is unsurprisingly published in our best journals, particularly again this latest work with the transcriptional framework for understanding these unstable plaques. He's been the Harold Amos Medical Faculty Development Award. He's been sponsored or supported by the American Heart Association, the Robert Wood Johnson Foundation. He's been the ASCI, the American Society for Clinical Investigation Young Physician Science Award. He's a FAHA, Fellow of the American Heart Association. He's been given Teaching Excellence Award, Directors Excellence Awards. He's the incoming chair of the American Heart Association's ATVB Council Early Career Committee, which, as you know, many do, one begins to age out of the Early Career Committee just in time to lead it. But that's great because he shares his experience and mentorship, of course, with junior faculty and trainees across the AHA and beyond. So we are thrilled to have Dr. Payne here, although, coming from Birmingham and April 1st, yes, this is spring in Ottawa. So welcome, Dr. Payne.
Well, good morning. Can you all hear me okay? Perfect. Katie, thank you for the very kind introduction. Mireille, Katie, thank you for the invitation to join you all, and thank you all for joining me here at 7:30 in the morning. Our translational rounds is also at 7 a.m., so I appreciate the effort of getting out. So as Katie mentioned, so the title of today's talk, of course, is Spatial Mapping of Atherosclerosis, and we'll spend actually the majority of today talking about spatial multiomics or spatial transcriptomics, actually something relatively new for our lab, but an area we've kind of pushed forward in part because it allows us really to use exclusively human tissue. And I think you'll see some of the translational benefit of that kind of moving forward. So with that, I don't have any disclosures that I need to make, but I will put forth, I guess, a thesis, if you will, for today. And so that is, I think, in my opinion, is really high time that we really reconsider our understanding and definition of what we mean when we say the word atherosclerosis. And that is to say, atherosclerosis really is no longer sufficient, that term it is, to encapsulate the complexity of disease that we really face in modern medicine. And part of that is clinically, as some of the physicians in the room will know, that we really are woefully ill-equipped to recommend targeted therapies, that is disease-specific therapies that may target various versions of atherosclerosis or associated diseases that come along with atherosclerosis. And then for the scientists in the room, I think it's really important that we really start to reconsider how we classify atherosclerosis. We tend to paint with a very broad brush. And that is to say to maybe start to reclassify atherosclerosis as an endotype or a disease-specific event. I put this forward first, and I hope by the end of the talk you understand why I may be pushing this direction based off some of the findings that we're having. But with that, I think with any grand rounds type presentation, I think it's important, at least from my perspective, to start with the type of patient that we're really trying to address here. And so I'll present to you briefly the breathless woman. In this case, who's a 62-year-old woman who presents to your emergency department with shortness of breath. She's had these chronic symptoms of dyspnea on exertion, that is shortness of breath with activity, for several years. But the symptoms over the past 3 weeks have started to worsen. She also notes a, quote, chest fullness. These symptoms are associated with a loss of appetite, this non-productive cough that she has attributed to your lovely spring that you're waiting to unfold here. Past medical, so a lot of risk factors. She has rheumatoid arthritis, is diagnosed over 10 years ago. That's moderately active with positive seroactivity. She has RA-associated interstitial lung disease, diagnosed about 4 years ago. She's got hypertension, dyslipidemia. Her statin use has been limited due to concerns about related myalgias. And then she's a former smoker that quit about 5 years ago, again, at the time of the diagnosis of her interstitial lung disease. When you're seeing her in the emergency department, you'll notice that her vitals are not terribly out of control. Her heart rate's about 104, but she is requiring oxygen at 92% on 2 liters. Exam, again, she's in some moderate distress, again, saying she's short of breath. She's got some chest fullness. Her pulmonary exam, you note these, for those who've done medical school, these classic Velcro-like crackles, no wheezes on her exam. Again, her cardiovascular exam is noted for being tachycardic, but no significant volume overload on her exam. And then the rest of the exam remains unremarkable. You see her EKG here, and while I won't put anybody on the spot, always follow the circle. So you see that there's some diffuse ST depressions. Again, your concern here is that she has diffuse perhaps diffuse ischemia. Furthermore, her troponin lab value is positive and elevated in this case. She's got a mildly elevated brain natriuretic peptide, or BNP. Not surprisingly, her CRP and ESR, estimated SED rate, are both markedly elevated. And then again, you see her lipid profile with an LDL of 95 and an HDL of 38. And so her working kind of admitting diagnosis is really a concern for interstitial lung disease exacerbation, as well as an in-STEMI, which was treated conservatively initially. As she continues through this hospital stay, you start to dig back through her records, and you notice that she actually had a perfusion study now 2.5 years ago that had normal perfusion with a normal ejection fraction or borderline ejection fraction. Her PFTs again show this underlying interstitial lung disease. And then she had a lung cancer screening CT, which again notes profound kind of coronary calcification. Again, follow the arrow sign here, where you can see marked calcification of the coronary vessels. Her echocardiogram during this hospital stay now notes that there's actually a regional wall motion abnormality, which, again, not to force everybody to go to school here, you can see along the inferior wall, you've got some inferior akinesis, and that is weakening or poor contraction of the inferior wall of the heart, concerning for coronary artery disease. Finally, she undergoes a left heart catheterization based off some of these findings. And as you can see here, documented below, the punchline is that she has severe 3-vessel coronary artery disease. And if the image on the right finally plays, you'll see here that her right coronary artery, there it is completely occluded with collateral vessels that has formed. So this disease has been ongoing for some time, and she's had the chance to develop, but she's got severe coronary artery disease on top of everything else that we've talked about today. Furthermore, her right heart catheterization at the same time really getting to the punchline shows that she's got some degree of moderate pulmonary hypertension. So this is a rapid run through her case, but at the end of this, as she's moving forward, now we've got a laundry list of situations and diagnoses we're dealing with, including, again, perhaps an ILD exacerbation, acute heart failure, acute coronary syndrome at this point with an NSTEMI, chronic ischemic heart disease, and again, moderate pulmonary hypertension. And this is not uncommon for us to see in clinical practice. But I think what I'm always drawn to is, especially from a clinical standpoint, we tend to stay in our lane, if you will. It's either a pulmonary problem, a cardiovascular problem, a vascular event. But really looking at this, to understand that the whole in this case is greater than the sum of her parts. And so to me, if I say what's the fundamental issue here, of course the answer is ongoing, pretty uncontrolled inflammation that's led to, in this case, a whole allotment of various diseases. But for the case of our study today, clearly has led to chronic coronary artery disease that's been independent of some of our more classical risk factors that we may discuss. So for the overview of today, I hope you take away from this really an appreciation or understanding of how inflammation can drive coronary artery disease. I hope that's not new information. And our current limitations, though, as far as our ability to have immune-targeted therapies. I also hope you understand the importance of kind of altered glycobiology, a new area of focus for us, and I'll explain why we've made this pivot, and how this may contribute actually to the development of vascular disease, and why that may be important for vascular inflammation. Furthermore, I hope you can appreciate, again, this new or somewhat new technology of spatial multiomics, specifically transcriptomics, and I'll show you some examples of spatial glycomics as well, and how this may be a new powerful tool for us to discern mechanisms of atherosclerosis, again, in human specific patient-derived tissue. And again, also finally to appreciate, again, our ongoing efforts to try and integrate these multiple different platforms to kind of really underscore an inflammatory signature of coronary artery disease that I think will allow us to really have a more refined understanding of what's driving some of these diseases. So again, focusing on inflammation, I think since Dr. Ross's hypothesis in the 70s, it's been understood that there's this response to injury or chronic exposure that leads to this cascade of events, leading to the production of various cytokines that can then lead to immune cell activation that then again may degranulate, leading to the release of proteases. And unfortunately, you get this chronic feed-forward mechanism of inflammation that once it's set in motion, it's thought over the course of 2 to 3 decades may lead to some of the disease phenotypes we're seeing with aggressive coronary artery disease. Now, some of the targeting this, again, it's been known for, again, the better part of now 5 decades, but the ability to target inflammation clinically has really remained somewhat limited. And so these have been some of the targets, again, most of them falling along this pathway known as the inflammasome. So whether that be targeting interleukin-1 beta with the host of agents, as you can see here, most classically canakinumab with the CANTOS trial, and then colchicine with an array of trials showing kind of mixed reviews. And I just highlight 2 of them here, as well as perhaps targeting interleukin-6, again, a downstream mediator of the inflammasome with either colchicine or low-dose methotrexate. And you can see how this may interrupt part of this inflammatory cascade, but really the bulk of clinical translational inflammation targeting in coronary artery disease has focused on these agents. And what you can see here, whether it be from 2009 with the Jupiter study, again, in this case, looking at patients who responded with higher CRPs for specific statin therapy, down to the CANTOS trial, again, using canakinumab, to the more recent colchicine trials, you can see here that there's been some success, whether you look on the right here for all-come outcomes, but with a relative reduction or relative risk reduction, excuse me, of about 22% in some of the most recent colchicine trials. But what I want to underscore from this, one of the reasons you don't necessarily see a lot of people walking around taking colchicine for chronic coronary artery disease, is that there's a number of drawbacks, concerns, and side effects. So canakinumab notably had a number of adverse effects, including neutropenia, leukopenia, fatal infection, primarily in the elderly and diabetic. And, newsflash on this one, this is the exact population we're trying to treat, as well as an increased risk of mycobacterial infections. And then colchicine, again, I've been known to prescribe colchicine for this scenario. I have to at least quote that there's a risk of pneumonia when doing this. So we have to be somewhat very selective in which patients we choose to treat with these agents. So what we're left with as we're trying to move forward is that despite, again, 50 plus years of understanding inflammation is important, we still have several limitations to seeing that translate or kind of bridge the gap between our basic science and clinical medicine. And so, again, as I write here, that despite all this robust preclinical data, we really just have one pathway at the moment that we are able to use for immune modulating therapies. So to me, this really underscores the importance of us continuing to explore alternative targets and really have a deeper understanding of how we may be able to interrupt inflammation if we are to really overcome some of these events with coronary artery disease. So at the same time that we've understood the role of inflammation, really the landscape for atherosclerosis has shifted. And this is what I was alluding to at the beginning. And so part of this has really been that the risk factor profile for atherosclerosis has been shifting. That is what was classically seen, say 40, 50 years ago with predominantly men with hyperlipidemia or smoking risks have started to see a shift towards various demographics. Again, an example of the woman I presented in our initial case. We've seen that an advancing understanding of lipoproteins has been causal to atherosclerosis, but again, there's been an increasing understanding of residual risk and other areas that may be undertreated or underrecognized that may be driving disease. And then I think critically, at least for our work, this appreciation that cells are not in a steady state existence. That is, these cells, and specifically smooth muscle cells, which we'll talk about for some length here in a moment, have this ability to undergo cellular lineage tracing or cellular lineage shifts that really challenge us to reconsider what's happening in the vessel wall versus what's happening with immune cells, and how maybe this leading to various events that we're facing. Furthermore, for those who either work in the cath lab or are treating patients coming in with acute coronary syndrome, we've all kind of been pushed to understand that once these plaque develop to a certain degree, we used to like to define them as either stable or kind of vulnerable or unstable plaque. And I put forth here, this is kind of the dogma of what stable versus vulnerable has meant, which is stable is to have again, thick fibrous cap with a lot of extracellular matrix, relatively few foam cells. Again, I'll put an emphasis on foam cell. Understanding that what this foam cell is in debate and is changing quite a bit. And in comparison to our stable, you can see here that a vulnerable plaque has this relatively thin fibrous cap, can have intraplaque hemorrhage, that is, it has blood vessel growth into the center of the core. You see that there's both perhaps microcalcification or macrocalcification. And again, importantly, here's our friend inflammation again with increased levels of foam cell recruitment and a pro-inflamed state. And again, classically, at least me as a medical student, was taught, oh, it is this type of plaque that causes acute coronary syndrome and myocardial infarction. However, if you actually look at the vessel when the event's happening, the mechanisms that are driving acute coronary syndrome are far more complex. And so if you using kind of, in this case, intravascular ultrasound or OCT, that is looking directly at the vessel either by a wire during some of these events, what you'll see is that acute coronary events are associated with multiple thromboembolic events really across the entire coronary tree. And there's also this concept of plaque erosion, as you can see here. That is to say, there actually has not been a plaque rupture. It's really a defect within the endothelial layer that may be leading to one of these events. So I think, again, with our understanding of inflammation, but inability to translate it, our shifting demographics, and now in this case, really a challenge to our understanding of what is a vulnerable plaque, again, I think it puts forth to us really the need to have a more refined or molecular definition of what is vulnerable and what is driving the development of some of this atherosclerosis. So what's been our approach? I think as a graduate student and definitely early on in my lab, our approach has been what you see on the left, which is focus on a mechanism you think of interest or a mechanism you write to argue is the most important and kind of zero in on that and focus on that somewhat exclusively. Like all things, COVID changed my perspective on some of this. So in 2020 or 2021, we took a completely different approach. That is to look really from an unbiased perspective at this tissue. And in this case, this is using spatial transcriptomics. And so, as Katie mentioned initially, we have focused traditionally on endothelial dysfunction, mechanisms of the extracellular matrix. And I guess in this approach, I'll present to you some of our work here and how, interestingly, it's actually starting to tie back together. So for those who are uninitiated into what spatial transcriptomic is, spatial transcriptomics or spatial profiling, this is the ability to really understand biology in spatial context. That is, we're not going to have to dissociate cells away from one another. And so as it shows on the slide, you're studying tissues in both their two-dimensional and three-dimensional contexts. And so in a very rudimentary way, you can think of this as using it for a GPS on the slide of tissue and trying to understand the transcriptomic signature or analysis, again, directly within the tissue. The benefit here, of course, is that it maintains tissue architecture and it allows for a multi-omic pattern or platform for really studying disease. What really interested me when I first heard about this is it affords the ability to use both preserved and fixed tissues. And so in our hands, all of a sudden, all of the biobanked, autopsy banked tissues from an array of patient results all of a sudden become available for you to test in a translational manner. And so and I'll walk you through how this specifically works, but it really combines, at least with this platform, there are at least two dominant technology platforms. For the one I'm going to show you here, it's going to combine fluorescent microscopy using kind of morphologic markers or antibodies with kind of high-end next generation sequencing. And so ultimately what you're able to do is to define these kind of regions of interest on your slides and really start to restrict your analysis to specific spatial regions within whatever tissue you're using. But in this case, we'll be looking at coronary arteries. As I mentioned, the workflow here is that, again, if you meet your friendly pathologist, as long as you have a block of tissue, you're able to do a fresh section, and then you can do either transcriptomics looking at RNA or proteomics in this case, both for either human tissue or for mouse tissue. And it's this kind of high-plex multi-layer ability to really now start to layer a transcriptomic signature with a proteomic signature has really been increased. And again, as I mentioned before talking, this has been a bit of an arms race for those of you who are either hanging out with the Vascular Discovery or going to any AHA talk. You'll already know that this has moved to kind of single cell spatial resolution. So if you wait 6 months, a new technology will be out. But this is in general somewhat of how this technology works. So how do we use it? So in this case, to examine, our objective we thought was to really trying to examine the differential programming, that is the differential expression within these vascular microenvironment amongst patients that we had defined as either stable or unstable with their atherosclerotic plaques, and again, using this similar technology. Sorry, go back. So again, as our methods move forward, in this case, we used all post-mortem coronary epicardiovascular tissue. That is, this is the site, if someone were to have a heart attack, this is the arteries that we're going into use for stenting or for percutaneous intervention. You can see here stability in our hands. We were tied to our original kind of definitions. That is, a stability was defined by the presence or absence of a lipid core, the presence of intraplaque hemorrhage, this neovascularization, that is the basal vasorum growing into within the plaque, monocyte and macrophage density, as well as the thickness of a fibrous cap. And I show you some examples here, both on the top and on the bottom. And moving forward, all of the same stainings we'll see here. So anything in yellow refers to something that has been staining positive for CD68. Again, we use this initially as a marker for a macrophage or foam cell. I will explain to you some of the complexities of that here in a moment, as well as what is pink or red. You will see here is a smooth muscle cells, and anything blue here is actually our nuclear stain. For those who have interest to say, hey, did you cherry pick the patients you have? You can see here based off risk factors, both stable and unstable really had very similar demographics. And I just highlight a few for you here as far as the presence of either a prior acute myocardial infarction, coronary artery disease, smoking, and statin use. Again, all of these are postmortem tissues, and the cause of death for these patients had a wide array of mortal events. And again, finally, this is just the workflow again. So taking those tissue sections, freshly sectioning them. In this case, since we're doing transcriptomics, we're going to define our tissue again based off these markers that I just showed you. Very uniquely, what happens is you actually lay down an entire array of these oligos. That is small little nucleotides that can bind to the specific mRNA transcripts for a whole transcriptomic atlas. So we're looking at about 18,000 genes on the tissue. And again, if they are bound, the machine is actually able to shine a UV light that then cleaves a marker that is basically a tag, if you will, that all of a sudden gets released. And so that's our ability to measure which mRNA transcripts were present versus which were not. And so again, you're combining kind of the ability of fluorescent microscopy with your protein marker, now with a pretty broad array of mRNA transcriptional signatures that can be retrieved and then sent for next generation sequencing. And so I'll walk you through some of our results here. Again, that was published in late 2024. But again, what this allows us to do is to now to ask questions about coronary artery disease, not just based off, what's a known cell type or what type of disease, but really start to restrict our analysis to specific areas without having to dissolve the tissue. And so that is, you can do an anatomic approach. You can start to ask questions about what the cells are doing, so a cellular approach, or again, as I alluded to at the very beginning, a disease or kind of endotype specific approach. So I show you this one just as really kind of proof of concept that we didn't make something up. And so we did all of this analysis. We selected multiple regions of interest and then did exactly what you're not supposed to, which is threw all the regions of interest back together. So this would be the equivalent of doing somewhat of a bulk RNA sequencing. And again, you can see here that there were notable differences between our patients who were unstable and stable. And again, I was very happy to see that some of the key markers, in this case, a transcription factor KLF4, remained positive despite this kind of ham-fisted way of throwing data back together. And again, I present to you also as well some of the gene ontology or sequencing or pathways that were enriched in this approach. But of course, this type of analysis is not at all what the technology is kind of meant for. But again, it's just kind of a proof to us that it's not creating or recreating a real, and that we're at least finding data that complements what the literature already shows. In comparison to that, now if we actually just start to restrict our analysis specifically, in this case, to the tunica media. So again, this is the region of smooth muscle cells that are thought to be either quiescent or contractile. That is not forming any type of disease. This is that the original ring of smooth muscle cells around the artery. What we observed actually is that there were significant gene differences between both our stable and unstable patients. Now just looking specifically at the media. In this case, you can see 74 genes upregulated versus 155 within our stable group. And so again, KLF4, again, a known mediator for smooth muscle cell dedifferentiation, remained positive. And that it, for us, really was the first sign of some regional specific differential gene expression patterns. For comparison, I'll show you what the intima showed. So again, if we kind of take a jump across the internal elastic lamina, which is this small little blue line that you're seeing here. So now looking at the same or thought to be same smooth muscle cells that have invaded into the vascular lumen, now we see again a completely different set of differentially expressed genes, again based off stability. And if you put all this together, in this case, looking at the intima, you can see that we saw an array of different pathways that were upregulated, again, now based on disease status, as opposed to just tissue architecture or cell type. And again, I'll just highlight, many of them were related to either autophagy, hemostasis, cytokine signaling, again, pointing towards inflammation, but now in a very regionally restricted or a regionally restricted appreciation for where these events may be happening. Now, I've alluded twice already to this importance of CD68. And so the reason why this is important will become more apparent over the next 3 or 4 slides. Our first analysis of this, again, initially going into this, we thought the CD68 was really just a marker for our macrophages and foam cells. And you can see here that there actually were not that many differences between the foam cells in stable versus unstable tissue. And that honestly, in hindsight, is not too unsurprising. A macrophage is a macrophage. It's just really the biggest difference we saw was the number of them that were present in one disease type versus another. But what we kind of, I guess, fell asleep on and we're rapidly awoken to is that the vascular smooth muscle cells, they themselves can de-differentiate. That is to say, what is a contractile smooth muscle cell can become its own foam cell-like or macrophage-like cell as it starts to eat lipids and LDLs that are in the plaque core. And again, that's been driven by this same transcription factor, KLF4, which again, I've shown you twice, was differentially expressed in our unstable conditions. And so looking at this, what we actually started to do was to look at what are some of the signatures of the cells, quote unquote, that were positive for CD68. And I'll back up for just a second because you may be asking, how did I get some of this data? If the technology we're using not only allows you to regionally restrict, but you actually can gate specifically to your own marker. So that is, I asked the machine only to sample from regions, in this case, that are staining yellow. And so this is a good example of how there were a lot of, quote, CD68 positive cells within the lumen of this unstable plaque. And this is effectively what we only sampled. So that is segmentation, the ability to really isolate down to a specific protein marker and ignore the rest of the other tissue. This is not single cell. Again, this in the year or so has advanced to single cell. But at the time, this was a strong ability to specifically look at a specific protein marker. So understanding that, what we started to recognize is that our CD68 positive population was not homogeneous. And if you look here, that is, we started to identify a region of cells that were both hybrid or myeloid. That is, they had genetic signatures similar to myeloid cells, but some that also shared some signature with smooth muscle cells. And I'll just for comparison, these are some of the samples from the medial smooth muscle cells. Again, the ones that we think are contractile or kind of quiescent. Shown in a different way, at least here on a PCA plot, what you can see here is that there's a kind of heterogeneous display where you have your medial smooth muscle cells in one group, you have your CD68 known myeloid cells, and then you have this kind of array of different cells that are sharing these hybrid phenotypes, both as somewhat smooth muscle cell, somewhat CD68 myeloid. And then importantly, we're actually able to map that back onto the tissue. And so what you can see here is that our classic myeloid, presumably foam cell macrophages, were actually hanging out presumably predominantly in the lumen plaque, as you can see here is an example, versus comparison, our hybrid cells were really densely populated within the core, which again somewhat makes sense, right? If you're having a developing core, the ability of these smooth muscle cells to de-differentiate into foam cell-like agents as they're kind of consuming lipids and cholesterol and LDL again, makes sense. But now, instead of just saying CD68 positive, we're able to say there's presumably two different cell types that are both anatomically different and molecularly different. And I show you that here, which is to show that our hybrid cells, again, as we've kind of alluded to, really had undergone this epithelial mesenchymal transition. And I think for the first time showing the genetic differences between both these myeloid and hybrid cells as far as their genetic differential gene expression. Finally, here, again, I'll just as a teaser show you that our next frontier, and I think this is ongoing work, both in our lab as well as others, is starting to look at these in a similar fashion to patients that develop different, I'll say, types of atherosclerosis of severity. Again, for those who work clinically, you've seen patients that have really heavy calcification versus those that do not. And the mechanisms of that, at least what's clinically important, remain to be really better understood. So at least in our case, we looked at some patients that had really heavy macro calcification. As you can see here, these would be these rock hard arteries that are difficult sometimes to stent. And again, we show here some of the differences that we're seeing genetically, at least based off the smooth muscle cells within the media and intima, and highlight some of the signaling pathways that were done. Now, just as a teaser, and if there's more questions, I'm happy to answer this maybe with the time at the end. One of the things we're looking at now is to really start to use systems biology approaches to understand, again, some of these smooth muscle cells. And specifically, this allows us to integrate our data with publicly known single cell data sets, really with the hope of identifying vascular smooth muscle gene modules and really start to do network visualization. And so what this allows you to do is to pour in a lot of data from not only ourselves as others, but then to spatially map it back onto the tissues that we have. And so, again, I think this is the next frontier. This has already been presented, 6 months ago at AHA, some of the ability to do this, but really to now define these cells, not just by one or two specific protein markers, but really to start to have an array of different modules. That is 6 or 7 different types of smooth muscle cells, and understand what they may be doing at specific times and how they may be progressing, not only along time, but also in response to different agents and stressors. So the takeaways from here are that we've seen now this unique spatially resolved transcriptional signatures that can be regionally restricted, both either in the intima or the media, and again, pointing towards some of those pro-inflammatory and pro-thrombotic events. We see that the ability of spatial deconvolution, that is targeting specifically those CD68 cells, allows us to really start to tease apart what is a heterogeneous cell population despite sharing similar morphology markers. And I think really it just highlights the potential again for us to look at atherosclerosis, in this case coronary artery disease, through an unbiased and disease-centered approach. So with the little bit of time that I have left, I really want to transition and talk to you a little bit about glycobiology. And if you're saying to yourself, where's the jump to glycobiology? That's the same thing I said when someone approached me with this question. And so I hope that I can convince you, as I was convinced, that I think this is also a worthwhile question. And not only that, it's really tied nicely to this kind of spatial approach to understanding disease. And so for those, again, who may be like, okay, what's glycobiology? It's important to understand that while you have genes and then proteins, these proteins can have a ton of different complex carbohydrates, that have different levels of carbohydrates and glycans that can be placed on top of them. And so think about this as, I'll show you an example in a second, but really the leaves on a tree, if you will. And I'll show you an example of this in a moment. But it's important to understand that these N-glycosylation events really lead to an array of different patterns that are on top of a protein. So it's carbohydrates being placed on the N motifs of these proteins. And so you can have different settings of these. You can have what are kind of the rudimentary or some of these high mannose proteins. So if this is the protein here, these longer structures that have multiple levels of mannose. And then they become progressively more complex. So you progress from the initial states of high mannose to these hybrid structures to then far more complex structures that are on the ends of these proteins. My understanding of it, what got me interested in this, again, as I alluded to, this analogy of a tree, that is to say the roots of the protein here are your DNA. Your proteins and peptides, of course, are the trunk and limbs. But really, the leaves, what we would define or what you recognize as a tree, is a lot of these various different carbohydrate structures. And again, I think this goes pretty woefully underappreciated because importantly, these themselves can have pro-inflammatory and cellular differences. And again, in our initial approach, even looking at genes, or in the case of looking at proteomics, it's ignoring the fact that these structures are there. And then importantly, just like any tree, if it's winter, spring, or summer, the way these leaves look change. So you're seeing dynamic changes in these carbohydrate structures that may reflect disease outcomes. And so part of that is driven by the fact that these same immune cells that we've been talking about, whether it be macrophages or circulating monocytes, can actually bind to these carbohydrates, and specific carbohydrates may lead to binding and then invasion into the wall. So again, the circulating immune cells are able to recognize if there's been a temporal change in some of these glycan structures, again promoting some of the vascular inflammation that we've been discussing. Just as an example of this, that way don't want you to think I'm just preaching to you. Here's an example of an adhesion molecule, specifically in this case, ICAM, which has a litany of information tied to its involvement with atherosclerosis. And as you can see here, if we look at different types and advancing lesion types, whether it be kind of early stage of atherosclerosis, again, this is all human tissue, to more advanced disease status, you can see that ICAM, of course, the expression here in red starts to increase. And it had been known that some of these complex N-glycans also increase with disease. Again, these red dots here are a lectin binding assay. That is the ability to kind of fluorescently visualize differences in these carbohydrate structures. What had not been known until this manuscript was put out is that both the hybrid and high manostructures are also present. And so it was importantly thought that some of these high manostructures may also promote a more pro-inflamed status. So this led us to really say, here are some of the challenges that we face in understanding the glycobiome, but importantly, any advancement in understanding the N-glycan signatures and N-glycosylation would be a novel breakthrough. Again, those of you who work in the lab understand that it's difficult to do any genetic manipulation of N-glycosylation. You've got an array of different cell types, proteins, all with different N-glycan biosynthetic pathways. And again, it depends on the cellular state. So you have multiple moving pieces that are difficult to kind of entertain and control. So hence we said, well, why don't we look at it from a spatial standpoint? I've shown you this slide already. And what I want to highlight for you is specifically looking at the intima of these arteries. We really took the initial almost 3,000 differentially expressed genes and resolved them down to about 162 that were, quote, glycan related. That is, someone went through all of these genes and said, is there a glycoprotein involved, or is it known to be glycosylated? So if we take that very refined cell population, or excuse me, gene signature and gene list, very early on, what you start to see is that amongst our unstable group, of course, you've got an increased signature for immune responses based off these 162 genes. That's in comparison to our general vascular homeostatic signatures that we're seeing for the stable. So the question we had is that, can we tie and integrate these kind of digital transcriptomics with some of the vascular glycome? And I'll tell you that what we started to see is that within here, if we look at, again, just the intima itself within these genes for these glycobiology related genes, I showed that these are some of the top 25 differentially expressed genes. And that, again, you can start to see that there may be some unique patterns that may be promoting or associated with disease status. Importantly, if you look at the pathways here, really what comes out is a N-glycan biosynthetic drive that's associated with disease burden, and specifically unstable disease. And I'll just highlight again that there's this biosynthesis for heparan sulfates, the extracellular matrix receptor interaction, as well as this N-glycan biosynthetic pathways that come up twice. And again, just so you're aware, I'll highlight to you specifically which genes were driving the signature, as you can see here on the left. And then I've highlighted them for you here as far as the known biochemical pathways that may be involved. And so what we're seeing here is that these may be upregulated with unstable patient disease, at least on a transcriptional level. Now, to tie this actually specifically to a glycan, we took the same patients that we used for our transcriptomic analysis and have now done spatial in glycomics. That is similar section, but instead of looking at the genes, we are pulling off the N-glycan structures. So instead of having about 18,000 genes, now I have a library of about 50 N-glycans that we're looking at. And just for the sake of time, it's very similar here that you can actually spray these slides with a PNG ACE, again, that basically cleaves the N-glycans, and using kind of a mass spec approach, you're able to specifically sample these N-glycans in a spatially resolved way. I'll show you an example of that here, which is to say these kind of circles, and you can see clearly the resolution is different that we can get with transcriptomics. But again, the circles here are identifying within our tissue blocks where is the media and intima of these patients within these coronary vessels. And then what you get is what you're seeing here, which is basically various heat maps of different expressions of specifically each glycan product. So as you march through, you'll see that for this N-glycan structure, here's the resulting heat map. And then you kind of move forward and you can start to integrate all of this mass spec data back together. So the next, what I'm going to show you next is this heat map specifically, now not looking at genes, but looking at glycan structures. And I'll show you here again that it's a bit muddied. It's not as clean as the genes, but you can see that there may be some differences there. But specifically, if you look at some of the top 15 N-glycans, and again, the numbers here on this x-axis refer to some of those specific N-glycans. But I think more importantly, if you tie all this together, again, similar to what I did with genes, looking at the principal component analysis, looking at these N-glycans, now you're actually able to start to dissociate those patients who were stable versus unstable. And if you look at specifically what was driving them, these top 3 N-glycans, as you see here, actually all were some of the complex N-glycans that were there. And again, I'll point out that this was opposite of what we thought we were going to see initially, but now it's our ability to say within the media and intima that the presence of these, at least these 3 glycan structures, has been associated with unstable disease. And I think what was really timely, I guess, right before trying to head off to spring break, as it was published March 9th of this year, was that similar findings that these N-glycan complex structures in the plasma of patients with either acute coronary syndrome or advancing disease has been now associated with this. So initially, I put this out there to say that I don't think we're too far off the mark as far as what we're seeing at a tissue-specific level compared to what is being observed in a more clinical and translational setting. So finally, as we just wrap up, our future direction that we're looking at here is really trying to find out what's in the middle. So as you probably have recognized, we've done the genes with transcriptomics. We've now looked at the mannose, but we haven't looked at the trunk of the tree at all. That is to look at the proteins that may be involved. And what I'll put here is that these were some of the most frequently upregulated genes that were known to be glycoproteins. Again, ICAM, VCAM, many of these are adhesion molecules or extracellular matrix related proteins. And so one of our next steps, as well as I'll show you here the extracellular matrix pathways, but one of our next steps that we're trying to pilot is using kind of this spatial proteomic platform tied with what is called a lectin binding assay. Again, the lectin is able to bind the specific carbohydrate or the specific N-glycan, and then to provide basically an imaging of fluorescent ability to resolve this. So to us, this will allow us to really integrate and tie together what has been a genetic signature, a glycomic signature, now with a proteomic signature, really with the hope of identifying genes to proteins to glycans and having a very robust approach to understanding what is driving inflammation within coronary artery disease. So with that, I will conclude. I just want to leave you with the idea that clearly this is really just the tip of the iceberg of trying to understand some of this in a spatially resolved manner. And so, of course, I would put forth that we need to continue to understand this approach in an unbiased manner, and that it's going to be important that we move forward in kind of somewhat of a systems mechanisms of vascular disease. And I think part of this is going to help us to refine some of our molecular disease-specific definitions. And finally, as is important clinically, to move forward to identifying new biomarkers, whether that be protein or glycan specific, and ultimately with the hope of trying to have therapeutic targets and strategies. So with that, as we always say, I don't do any of this by myself. And so I want to highlight at least two folks from my team, both Dr. Gaston Nadui as well as Stephen Bizek. Gabriella was involved with all of the spatial transcriptomic, and Bizek has been driving a lot of the work in the glycan structures, as well as everybody else here in red, Dr. Bell, Dr. Patel, Dr. Drake, who helped us with our spatial and glycomics. And with that, I'd be happy to take your have some discussion and take your questions. Nice.
If anybody needs to bring back the song, let me know. But thank you, Greg. That was very interesting. Very distracted by that. So one of the questions, and you sort of alluded to it in that study about the plasma, like
Yeah.
Obviously LDL is litigated. How do you sort of put those things together? Is this driven obviously by glycemia in some ways? Obviously not entirely, that's not the entire source of these. Just thinking a little bit back to those scenarios, the patient's risk factors, what have you thought about?
Yeah, no, it's a great question, which is, there's a lot of different drivers, as you're alluding to, a lot of different products that can be in glycosylated, as well as a lot of different drivers for it. It's still very young, is all I could really say. And so we focus primarily right now on the vascular cells that are present. Also, just knowing that it's been difficult, at least in this type of platform, to say, look at LDL, to look at hemoglobin. I think one of the approaches we're hoping to do is using a large patient plasma sample, so some of these are available, is to do a high throughput in glycan screening. And I think that would then start to pull out, hey, what may be LDL associated, what may be hemoglobin associated, and then you could differentiate those based off, say, A1C or other agents in disease. So I think it's an early, shot across the bow of like, hey, can we look at this? What I'm pleased with seeing is that whatever, at least if it comes down to saying complex and glycans are important, we're seeing that similarity between what's in the plasma and in the tissue. Now, if it's going to be a specific in glycan, I think that's going to be the next challenge. And then finding that at the right time, at the right place will also be an additional challenge. But I think this at least sets in motion that type of approach. Mhm.
But I'm wondering, I'm not saying about method of how proteins get glycated.
Yeah.
Are there, would there be interest in looking at enzymes and like the upstream of that? Like what are the enzymes function conjugated? Is there activity level?
Yeah.
Are those targets?
Yeah, I think we've got at least the list that I showed you here, there's at least 8 to 10 or so. And again, there's not a whole lot of enzymes that do this. And so that's the interesting and challenging aspect of this. It's not a one for one. It'll be really a concoction of these different enzymes that work in tandem that may be adding to this. And so we've got a list already of about 10 or so that show differential genetic expression. again, the next step would be, can we look at enzyme activity? Correct.
So much for the talk. You're being really, really interesting, and I think this field of biology is really gaining traction.
Sure.
It's very timely. I'm very curious if you've also looked at glycans and coronary oscillation, and the reason I ask this is because there's actually been a lot of work in the brain and
Yeah.
changes to glycomics with relation to stroke and aging. And
Yeah.
a whole lot of blood oscillation, and I know that slightly different functions and blood oscillation more to do with adhesion molecules and some are preventing oscillation more to do with something for stress. So I'm just curious.
No, it's a wonderful question. We have not. I will tell you, it's not something missed on us. To Katie's earlier question, there's a entire group at UAB that focuses a lot on, say, O-glycosylation with diabetic stress. And so it's a needed area. I think where I've seen is O-glycosylation, at least in like responses to stroke, as you mentioned, Alzheimer's. But it's something we can do. I think it's specifically, honestly, just one thing at a time, right? So we focus first and foremost genetically things were pointing towards N-glycan biosynthesis, and so we just followed that trail from what our gene ontology was suggesting to then say, okay, we need to look at the N-glycan signatures. What I think is difficult too is that using genetics to determine how glycosylation events change inherently means you're going to be really narrow in what you're seeing because again, it's not very transcriptionally regulated. So I think we're again, I showed you that image of the scope looking focus. I feel like we're a little focused again, but the hope is to kind of spread it back out and to say, can we look at N-glycan and O-glycan? The other technical limitation, of course, is how you generate tissue for an N-glycan analysis is going to be different than O-glycan. Doing it on the same tissues it is a bit of a hurdle.
My question is, do you think that the relation of glycans versus the and an increase in biosynthesis, or do you consider that perhaps degradation of their might be affected, in the autophagy field? We know that autophagy becomes presently affected by processes that it's in one of your top pathways affected.
Yeah.
Glycophagy and specific autophagy subtype. So knowing that lysosomes are complex, are some of these products integrated autophagy breakdown of lysosomes and
Yeah. Murray, it's something we had not considered, but I think it's a wonderful example, especially since autophagy came up again as one of the highest differentially expressed pathways before. So something I think we absolutely need to look into, and a great suggestion.
And if I could follow up with one other question, the work that you're characterizing spatially, pointed out rightly that the cells would not work doing X amount of X. I'm wondering if you have any ability to marry your data box with human genetics. Now,
Yeah.
there are primary samples you might not be able to do it, but even to actually sequence DNA of the plant itself, as we know, there's clonal expansion and there's mutations. There are things that, depending on when where somebody's DNA samples are going to be taken, it might not match what's actually genetic composition of plastic security.
Yeah. So, I mean, I think so. I put this slide up because I think our next step has been what the systems biology approach allows us to do is to take all, say, of the single cell genetics that are available, you cluster and redefine that, and then start to map that back out to the data set that we've generated. And so that is one way that we could potentially try to integrate is to say, if you give me, patient single cell information here, we can start to map that back out to see if there's similar signature. Yeah, I think broader to your question is to say like clonal expansion, things of that nature, that is missed, I think, with this type of approach. Again, it's because right now we're saying the cell is there. It is not, oh, did we have a chip expansion that's leading to a different type of macrophage that may be more pro-inflamed. And so I think it's, again, like you said, we'd have to think really carefully how to approach that. Because right now we're, as you know, linked into like each patient being itself. And so if that person had a clonal expansion, and perhaps the way to do it is you define a group that has a clonal expansion who doesn't, and then try to start to do it in this way. I think it'd be a very interesting question, but we haven't done it yet. So
I just think of labels of QoS risks. You know, there are tons of you know,
yeah,
so SNPs that associate with risk and associate with different phenotypes that but we have no idea means actual.
correct. What would help us is that for all the scientists doing that work, if they start to resolve that to say SNP A, B, C, all through Z, here are some common mechanisms that we can then chase for. That would be very helpful. Excuse me. That would be very helpful for us to really better target where we're looking. If not, it's still going to be really, really broad. And I think the challenge again is, and what we've tried to do, at least in our lab, put that back towards having the rubber meet the road. And so it's got to have some physiologic output to it.
Thank you so much.
Thank you.